IT team, can we see the Rustemer's lecture, please?
Hello, my name is Thomas Rustemeyer, and I'm working as a dermatologist at the Department of Dermatology and Occupational Dermatology of the Amsterdam University Medical Centers in the Netherlands. Today, I would like to share some ideas about the recent developments which we have achieved by understanding pathophysiology of allergic conjunctivitis and which might help us to develop further in vitro tests in the future. First of all, I would like to declare that I have no conflicts of interest with respect to the contents of this presentation. This could be one of our patients showing chronic hand eczema. By eye, it's hardly impossible to diagnose it as either atopic dermatitis, irritant conjunctivitis, or allergic conjunctivitis. Further information is needed. Similar now, we do see eczema at the lower belly. Only if we have this clue, one might come up with the idea that this might be allergic conjunctivitis. Thus, in general, we do need patch tests, where we apply the allergens on the back of the patients in order to find the right diagnosis. But this is really quite time-consuming for our patients and work intense for our personnel. Until now, it's the only validated method to find the allergens and to make the link with the medical history and the clinical presentation of the patient to find the right diagnosis and to give appropriate advices to our patients. Taking a skin biopsy, which shows in conjunctivitis a lymphocyte-rich infiltrate, is neither a good option now. But we do know that allergic conjunctivitis shows a delayed allergic direction type, which is mainly mediated by effector T cells. This might be a clue. We know that in allergic conjunctivitis, during the sensitization phase, quite a lot of allergen is needed in order to activate the antigen-presenting cells, which are in the epidermis of the Langerhans cells. Thus, to get triggered and subsequently to migrate as matured dendritic cells out of the epidermis through the dermis towards the draining lymph nodes, where they can prime naive T cells to become allergen-specific effector cells. They are not only in the primary lymphoid organs, but they are also circulating through our body. Thus can be found in blood, for example. But upon subsequent contact, even with a low amount of allergen, these cells can find the right spot where the allergen has made new contact, get activated and secrete inflammatory cytokines, causing the eczematous reaction where the patient presents himself in our clinic. And this is important, that these allergen-specific T cells can be found in peripheral blood. And by drawing blood and separating these cells, which are part of the peripheral blood mononuclear cells, PBMC, the white blood cells, can be a tool to diagnose allergic conjunctivitis by in vitro methods. Thus, we have our patient from whom we draw blood, isolate the PBMCs, and bring them into culture in the presence or the absence of allergens and the cytokine supplements in order to stimulate the activation of specific T cells. And this can then be measured after a couple of days by the release of specific cytokines or upon addition of radioactivated thymidine by measuring specific proliferation. This slide summarizes our current knowledge. In particular for nickel, as the most frequent allergen still, many studies have been conducted with it. And if we compare these in vitro results with our patch test data, which have an accuracy of 76%, we do see that the general proliferation test is inferior only upon supplementation of cytokine cocktails, in particular IL-4, IL-7, by which in particular Th2 T cells are activated, Th2, we do achieve a higher accuracy. Similar holds true if we measure the release of specific cytokines, and then IL-5 upon addition of IL-4 and IL-7, we have accuracy, thus sensitivity and specificity taken together to accuracy of 83%, which is even better than the standard patch tests for nickel. Also for other contact allergens, these studies have been confirmed, although the number of trials is limited. These in vitro assays are really promising for the future. Maybe not for screening all of our patients, but if we suspect occupational dermatological problems where we do have a clue that certain work-related allergens are really important. And they are important in diagnosing the right culprits in severe drug-related reactions, such as in toxic epidermal necrolysis, where performing patch tests can be dangerous for our patients and the sensitivity is low. Here, these assays will have an important role in the near future. As a spin-off, these assays also allowed us to identify the subtypes of T cells involved in allergic contact dermatitis. In particular, CD4 positive T cells with the hormone receptor CLA and showing the migration receptor CCR4, CCR10, and CXCR3 belonging to these different types of effector T cells. All these T cells are in the epidermis and produce cytokines, which subsequently diffuse also in the upper epidermis, where they can be found in the stratum corneum. By tape stripping this stratum corneum, the cytokines can be analyzed, which is a sensitive method. Currently, we are able to identify many cytokines, including this variety of interleukins and tumor necrosis factors, interferon gamma, and other chemokines belonging to the CCL and CXCL family. But this is only the beginning. As you can see, you can find different reaction patterns, but I would like to focus on IL-16. IL-16 is mainly found in the stratum corneum when allergens are applied in allergic contact dermatitis reactions, but the amount is not increased in irritants, as you can see. Thus, IL-16 is a promising cytokine to diagnose ACD in the future. Tape stripping is non-invasive and will have a bright future if we implement it in a clinical setting. But also tape stripping in other skin diseases will be important, such as in pruritus with IL-31. I would like to thank all my colleagues who have contributed to this work, and I thank you for your kind attention.